Thank you. Once more time. Okay, that's I always forget. Okay, so we're going to discuss endocrine system first, chapter 41, and then move to musculoskeletal system, which is chapter 48 and 49. And also, before we discuss, please, in the human body, out of 11 organ system, if you both remember, we have the nervous system and the endocrine system. These are the two systems which control the whole human body function. Endocrine system and the nervous system, which we discussed earlier with anatomy. Endocrine system controls functions with the help of hormone. Nervous system controls function by means of neurotransmitters. One big nervous system kicks in millisecond, and endocrine system takes time to kick in but lasts longer. This is the preview of the endocrine system. And also, folks, please remember for the endocrine system, all the glands which belong to endocrine system, their location, their secretion, what makes stimulus, and how it works. If you know those things, pathophysiology is like a water. But you have to know the normal thing first. Okay. Now, it says the categories of disturbances of endocrine function in terms of hypofunction, in terms of hyperfunction. Hypofunction, when the gland is not doing its job, not producing enough hormone, we said the gland is doing under hypofunction, under production of hormone. Causes may be, there are different causes. Please remember, congenital defect in the gland. Number two, disruption in blood flow to that particular gland. Maybe infection, maybe inflammation, or maybe autoimmune responses or some neoplastic growth or cancerous growth. Or maybe decline in function with aging. We do have all those endocrine glands. As we get old, the secretion gradually reduces. That's normal. But that also falls under hypofunction. Next, atrophy as a result of drug therapy or unknown reason, idiopathic we call it. Sometimes some drugs causes atrophy of those glands, and the gland doesn't produce enough hormone. Or the last one over here, we call receptor defect. All chemicals, neurotransmitter you said, hormone you said, in order to produce function on the body cell, they need receptors. Without receptor, nothing going to happen. So we do need receptors. So if the receptors are defective, hormone is not going to produce their function and falls under hypofunction. Now, hyperfunction, production of hormone, excessive production of hormone, we call hyperfunction. And the causes may be due to excessive stimulation, please remember, and hyperplasia of the endocrine gland. Not atrophy, hyperplasia or hypertrophy. Number two, hormone producing tumor of the gland. There are some tumor which produce hormone also. In small cell carcinoma of the lung, the tumor produces hormone also. Now, doesn't matter hyperfunction or hypofunction, please remember the tumor is the most common cause of gland dysfunction. Endocrine disorder, most common cause is Most common cause for endocrine disorder is tumor. Okay. Please remember. Now, categories of endocrine disorders. And also, folks, please, for endocrine system, remember the hypothalamus. Underneath the hypothalamus, we do have pituitary gland. And then this pituitary gland is connected with the hypothalamus with the help of what? What connects the hypothalamus with the pituitary gland? What is the name of the structure which connects the pituitary gland with the hypothalamus?
Is it the infundibulum?
I understand what you said. Infundibulum. Infundibulum. Please remember, this is all discussed. Infundibulum. Infundibulum connects my pituitary gland with the hypothalamus. And within this infundibulum, we do have network of blood vessels and network of nerve fibers. Network of nerve fibers and network of blood vessels together are located within the infundibulum. And this network of blood vessels carries secretion from the hypothalamus for the anterior pituitary gland. The network of nerve fibers carries hormone, two hormones, ADH, oxytocin, from the hypothalamus towards the posterior pituitary. Let's refresh your memory. Posterior pituitary hold those two hormones, ADH and oxytocin. Who produces those ADH and oxytocin? Who is producing it? Hypothalamus. Hypothalamus produces those two hormones and is stored within the posterior pituitary. But anterior pituitary produces its own hormone. Yes, so many hormones coming from the anterior pituitary, like the growth hormone, like the follicle stimulating hormone, luteinizing hormone, thyroid stimulating hormone, all are prolactin. They are all produced within the anterior pituitary. Okay, so like I'm giving one example because I have slide over here: primary disorder, secondary disorder, then tertiary disorder. Hypothalamus, pituitary gland, then third level is my gland we call target gland. Like I can take over here my thyroid gland. In order to stimulate thyroid gland, thyroid gland need hormone from the anterior pituitary we call TSH. TSH, thyroid stimulating hormone. Coming from where? Anterior pituitary. Without TSH, this gland is not going to produce any hormone. This T3, G4 is not going to be produced from the thyroid. Is it clear? So please connect. All these are basic things over here in the endocrine system. So the primary disorders is when the target gland, right now I'm giving example of thyroid gland is my target gland. If the thyroid gland is not producing their hormone, we call primary disorder. If thyroid gland is okay, my anterior pituitary is not producing the hormone, then belongs to secondary disorder. Secondary disorder. My hypothalamus is okay, my primary target is okay. Defect is in my anterior pituitary. That is secondary disorder. Tertiary disorder is when the hypothalamus is at fault. Look at that one. Primary, which is the target gland, like my thyroid. Secondary is my pituitary. Tertiary is my hypothalamus. Step by step. That's the pretty basic thing. Okay. So the primary disorders originate in the target gland responsible for producing the hormone. The secondary disorders, the thyroid gland is essentially normal. My thyroid gland is normal. The defect, who is at fault? Who is at fault in secondary disorder? Pardon? Pituitary gland. Anteropituitary or pituitary gland at fault. They are not doing the job. Hypothalamus is fine. Thyroid gland is fine. Both are okay. But the pituitary gland is not working. That is my secondary disorder. Now, my target gland is fine. My pituitary gland is fine. Hypothalamus is defective. Hypothalamus is not doing its job. Then belong to tertiary. Clear? Okay, the secondary disorders, the thyroid gland is essentially normal, but its function is altered by the defective level of stimulating hormone or releasing factors from the pituitary system. Tertiary results from hypothalamic dysfunction. Hypothalamus is at now fault. My pituitary gland is fine, my thyroid gland is fine. That's why I say second point, look at that one. It says pituitary gland and the target organs are understimulated because hypothalamus is not sending the message. So, for the pituitary gland, so please remember location of the pituitary gland, parts of the pituitary gland, anterior pituitary, posterior pituitary. Anterior pituitary we call adenohypophysis, if you remember, we call adenohypophysis because anterior pituitary produces its own hormone. Posterior pituitary, what is the name of posterior pituitary? What is the other name of posterior pituitary? What? I want to hear it from any person from Zoom, anybody. What is the other name of posterior pituitary? If they ask, what is the other name of posterior pituitary? I can call posterior pituitary, I can call neurohypophysis. Write it down. Neurohypophysis. If I say neurohypophysis, that means you're talking about posterior pituitary, period. Neurohypophysis. Anterior pituitary is called adenohypophysis. Anterior pituitary is called adenohypophysis. Posterior pituitary called neurohypophysis. Posterior pituitary doesn't produce any hormone. They store two hormones, I just said, ADH and oxytocin. ADH and oxytocin is produced within the hypothalamus, stored at the posterior pituitary. And then this posterior pituitary release those two hormones under command from the hypothalamus. ADH and oxytocin is then secreted from the posterior pituitary into the blood. Wherever they needed, they will go to work. Oxytocin causes contraction of my uterus. If you remember, oxytocin causes the contraction of the uterus at the time of the labor. ADH is needed when the body is dehydrated. Antidiuretic hormone. Okay. So the categories of pituitary disorders may be primary, may be secondary. Secondary is due to metastatic, somewhere else is problem going on, they spread to the pituitary gland. That's why we call metastatic lesion. Maybe this is one category of classification, primary, secondary. Number two is functional or non-functional. Functional tumors secretes pituitary hormone. Non-functional tumors do not secrete any hormone. So tumor is the most common cause of endocrine disorders. I already said that. Is that correct? Now, the manifestation of hypopituitarism, hypofunction of the pituitary gland, it usually occurs gradually, slow onset, can present as an acute or life-threatening condition. Symptoms, maybe look at the symptoms, maybe being chronically unfit. I'm not feeling well for months and months. Something going not well in my body. Feeling weakness or fatigue. I'm gradually losing my appetite. Impairment of my sexual function. Or cold intolerance. All these, like cold intolerance, because the pituitary gland, if you look at the pituitary gland, the antipituitary gland, it produces thyroid-stimulating hormone. Antipituitary produces thyroid-stimulating hormone. That thyroid-stimulating hormone is needed for my thyroid gland. So the thyroid gland can produce T3 and T4. Look at that. Pituitary gland is not in hypopituitarism. It's not doing produce their hormone. There is no more stimulation for my thyroid gland. There is no more T3, T4. As a result, my body T3, T4 supposed to maintain body metabolism. T3, T4. Is it clear? That's normal function T3, T4. Now, pituitary gland is not sending me the TSH. Thyroid gland is not producing T3, T4. That's why my body metabolism is low. That's why I'm feeling cold intolerant. Temperature is okay, but still I'm cold. For everybody's fine, but I'm cold because something is going wrong in my body. Sexual dysfunction, same things. FSH, LH, they're supposed to produce testosterone and estrogen. Okay, so please remember. Now, measurement of hypothalamic, please remember this we call axis right now, hypothalamic pituitary target cell hormone. So we need to know there's an axis we call hypothalamus pituitary target gland. Target gland may be my thyroid gland, maybe my testes, maybe my ovaries, whatever. Target gland depends on the hormone which produced by the antipituitary. So right now we are measuring serum cortisol. Is a steroid hormone. Serum cortisol is a steroid hormone. It falls under glucocorticoid. Cortisol is a hormone, falls under glucocorticoid produced by adrenal cortex. Who's producing it? Adrenal cortex. Adrenal gland, go back. Adrenal gland has two zones. Outer zone we call the cortex, inner zone called the medulla. Is that correct? Outer zone called the cortex, inner zone called the medulla. That outer zone produce different types of hormones. Those are all important. Like glucocorticoid, mineralocorticoid, and androgen. Those are three different types of hormones coming from adrenal cortex. Now, serum prolactin. What prolactin is doing? What is the function of prolactin?
Yeah.
Pardon? Milk production, very good. Production of milk. If the mother wants to breastfeed her newborn, she should have enough prolactin for the production of milk in the mammary gland. Without prolactin, no milk. Even though she has estrogen, she has progesterone, she already has oxytocin, but prolactin is not there. No prolactin, no milk. Please remember, prolactin is needed for what? Milk production. And oxytocin is needed for ejection of milk. Oxytocin is needed for ejection of milk. When the newborn starts suckling mother's nipple, the stimulus goes toward the hypothalamus. Is that correct? You look to connect those things. When the newborn starts suckling the mother's nipple, sensory stimulation from the nipple goes to mother's hypothalamus. Mother hypothalamus send message toward the posterior pituitary. Posterior pituitary release oxytocin, and that oxytocin, by means of bloodstream, causes ejection of milk. Provided she have enough prolactin, milk is there. Okay, so everybody's okay with that one? I mentioned a couple of things over here. Stay connected. Now, the number 3 is serum thyroxine, which is one of the hormone from the thyroid gland. Thyroxine is T4, and we do have T3 also, coming from the thyroid gland. And TSH stand for thyroid stimulating hormone. Thyroid stimulating hormone. Who produces it? Who produces TSH?
The anterior pituitary.
Yes, anterior pituitary produce TSH for my thyroid gland, so the thyroid gland can produce thyroxine T3 and T4. T4 is thyroxine. Okay. Next, serum testosterone, the male sex hormone, serum estrogen, and that is female. And we do have serum FSH and LH. Who produce FSH and LH? Anterior pituitary. Pituitary produces these two hormones, FSH, follicular stimulating hormone, and luteinizing hormone. These two hormones is needed working the female body, is working the male body also. And then we have to measure growth hormone, and growth hormone is working with the help of converting into insulin-like growth factor. I'm not worried about one. Insulin-like growth factor, growth hormone produce overall growth of the body. Then we need to measure plasma osmolarity and urine osmolarity because there is a hormone we call aldosterone, which is needed, which maintains my electrolyte. Okay. Please remember, these are all important hormones over here. Thyroxine, cortisol number 1, which is already in the list. Prolactin, where I break down prolactin already. Then thyroxine, which is coming from my thyroid gland. Not thyroxine only, we have T3 also. And we have TSH coming from the anterior pituitary. Now, the testes and ovary, they produce male sex hormone, female sex hormone in response to LH and FSH. Growth hormone. If I'm lacking growth hormone from very birth, my height is going to be short, dwarf, because pituitary dwarf. Or my height is okay. My height is right now like my other siblings, like my parents, but still my pituitary gland is producing more growth hormone or production of growth hormone. I don't have space to increase in length, but other things will happen. That condition in the body we call acromegaly. Acromegaly. I already attained my height. like that of my parents. Now, there is a feature of person with acromegaly. No lengthening, but the bone become thickened. Thickening of the bone will take place. No lengthening is possible because everything is closed. Epiphyseal plate we call is closed. Now, in adult, it's still, I am in growing period. My bone is not closed yet. The bone closes by age 25. Suppose right now my age is 18. My pituitary gland is producing too much growth hormone. In that case, my brother is 5 feet, my height is 7 feet. Gigantism. Look at that. My brother's height is 5 feet. Because of the pituitary tumor, my height shoots up to 7 feet. Because my bone is still growing. Is it clear? So please remember gigantism, acromegaly, dwarfism. Yes? All related to what hormone? Growth hormone.
The growth hormone.
Yes. Okay. Okay. And then import all these. Then we have T3, T4, thyroid. Thyroid gland also, which are, all these are coming from hormone also. Thyroid gland also defective before birth, and then the condition of that defective thyroid gland since birth that has a name we call cretinism. What? Cretinism. Cretinism, by birth, my thyroid gland is not there. It's not doing this job. By birth defective. Condition called what? Cretinism. So we need to find whether before the patient, the newborn, they start from the hospital, they get the blood from the heel prick blood, and do the assay of all those hormones. If we can detect that this child doesn't have enough thyroid hormone from the birth, and they start medications right after birth, their child IQ, because thyroid hormone T3, T4 is needed, T3, T4 is needed for my physical growth, mental growth, brain, spinal cord, and everything, mental growth, and the reproductive growth. Those are the three things or three sectors or areas my T3, T4 work. My physical growth, mental growth, and my reproductive growth. If we start treatment of that newborn, which is he came with no thyroid gland function, we call cretinism, we can prevent the child IQ. Not only IQ, but also he or she can have normal physical growth. Look at that, so important. Okay. It says, a dash disorder results from the lesion or damage at the gland. It's a primary, secondary, and tertiary. Please remember which one is primary, which one is secondary, which one is tertiary. Tertiary is blame goes to hypothalamus. Secondary, blame goes to pituitary gland. Is it clear? These are the hormones. Hormone essential for normal body growth and maturation. Growth hormone, insulin, thyroid hormone, sex hormone. Sex hormone is testosterone and estrogen. We call androgen. Everybody clear with that one? Please remember all these hormones. Okay. Now they start with the growth hormone. Growth hormone produced by the anterior pituitary, we already said, produced by the somatotrope cells in the anterior pituitary. This growth hormone is necessary, highlight, it's necessary for linear bone growth. Linear means in longitudinal length. That's what we call linear bone growth. Number 3, it stimulates cells to increase in size and divide more rapidly. That's what they call growth hormone. Growth hormone enhances amino acid transport across the cell membrane. For this amino acid enters into the cell, and this amino acid then is used for synthesis of protein. Next, growth hormone increases the rate at which the cells use fatty tissues or fatty acid. This growth hormone decrease the rate at which the cell use carbohydrate. Say, utilization of the carbohydrate decrease, utilization of fat is increased, synthesis of fat is increased with the help of growth hormone. This is the all job, these are all falls under growth hormone function. Now, if something happened, they are not enough or they are too much. Growth hormone deficiency interferes with the linear bone growth. One with dwarfism, I mentioned that one if you remember. And in adolescence, still growing, too much growth hormone will cause gigantism. Because I'm still growing. Or I have achieved my growth, normal growth, that my sibling, my other sibling, and my parent, still growth hormone is there. Then the condition is called acromegaly. Acromegaly. Please look at the diagram of that person with acromegaly. Remember all those features. Okay, so deficiency will result in short stature, we call dwarfism. Excess growth hormone results in increased linear bone growth, but this depends on what stage this hormone is coming. Causes of short stature. One is normal variance of normal. Number 2, low birth weight, may be due to chronic illness and malnutrition. That might be cause also, not only the growth factor, not only the growth hormone. Number 4 is functional endocrine disorders like thyroid hormone, like the growth hormone, or maybe due to chromosomal disorders. Second last is skeletal abnormalities, or maybe due to unusual syndromes. But please remember, maybe low birth weight, chronic illnesses, malnutrition, endocrine, important. Now, it may be a genetic short stature or constitutional short stature. Calorie malnutrition. Because of my poor condition of my parents' financial condition, I'm not getting enough protein. Chronic illness, important. Chronic illness, like end-stage renal disease. I'm suffering from chronic renal disease or kidney disease. Or I'm suffering from juvenile diabetes. The diabetes starts in very early age, and that diabetes is not well controlled. that also cause short stature. That is poorly controlled diabetes mellitus, type 1 diabetes. Okay, next is maybe malabsorption syndrome. I'm having enough food, plenty of food, but it's not undergoing absorption. My absorption system of my intestine is not okay. Like celiac disease, if you folks remember, Crohn's disease, celiac disease, ulcerative colitis, all those will lead to malabsorption. I have enough food, but I can't absorb. Next is excessive glucocorticoid administration. What is glucocorticoid? Anybody? What is glucocorticoid? Very common. Steroid, prednisolone, very common in the market. Prednisolone, like for COVID, this person, if his condition is not okay with COVID virus, they do inject those injections, prednisolone injection, prednisolone, steroid, life-saving medication, glucocorticoid. Please remember, put a note. That means it is one of these steroid, life-saving medication, prednisolone. What this glucocorticoid is doing for my short stature, this glucocorticoid sometimes is needed for that patient. Maybe he or she is having kidney disease. In order to prolong the life of that patient, I need to prescribe prednisolone. But on the other hand, this prednisolone in this body will cause my epiphyseal plaque. You have to have balance. So I need to give because of the chronic kidney disease. If I don't, patient will maybe survive for a couple of weeks. If not, then I have to prescribe prednisolone. Prednisolone in high dose will cause closing of my epiphyseal plate, which is supposed to function. As a result, when the plates are closed, my height is short. Is it clear? Yes or no? Everybody's okay with that one? Now, emotional disturbances. Some not happy. I'm healthy, but I'm not happy. That emotional disturbances. Okay, tall stature. Now we're going the other end. Tall stature, excessive growth hormone, constitutional tall stature, a child who is taller than his or her peers and is growing at a velocity that is within the normal range for bone age. If all a tall stature, maybe he is genetically tall. Other conditions, maybe Marfan syndrome, we call Klinefelter syndrome, Marfan syndrome. These patients with chromosomal abnormalities, they do also have tall stature. Please remember. Endocrine causes like overproduction of sex hormone, sexual precocity, early maturation, early onset of estrogen and androgen secretion, and excessive growth hormone. Now, the effect of growth hormone excess in adults can lead to overgrowth of cartilaginous part of my skeleton. Look at that one. Growth hormone is targeting which tissue? Cartilaginous tissue. not only the skeletal tissues, but also the organ, like my heart and other body organs are undergoing enlargement. Is it clear, folks? Now, the next is, it says, because of the excessive growth hormone, we do suffer from metabolic disturbances, resulting in altered fat metabolism and impaired glucose tolerance. I might suffer from diabetes. Okay. Acromegaly, I was hitting this part. Is that correct? Acromegaly. Due to what? What is the cause of acromegaly? Excessive growth hormone. Overproduction of growth hormone in adults after they attain their normal height. That will lead to acromegaly. Now, diagram on page 1195. Page 1195, we do have a diagram of a person who's suffering from acromegaly. Most common cause of acromegaly, which is coming from the adenoma of my pituitary gland, adenoma of my pituitary gland, which produces overproduction of growth hormone. Other causes, excessive secretion of growth hormone, we call growth hormone releasing hormone. And also, folks, in order to remember, let me go back. In order to remember, hypothalamus, when we said releasing hormone, whenever we said releasing hormone, the source is my hypothalamus, nowhere else. Hypothalamus, because I said releasing hormone. If I use stimulating hormones, pituitary gland, nowhere else. I'm not going to go anywhere else to look for them. You said stimulating follicle stimulating hormone, I'm going to go to the anterior pituitary. You said thyroid stimulating hormone, I will go to the anterior pituitary. When you use the term releasing hormone, I will jump into the hypothalamus. Hypothalamus produces 3 different types of hormones. ADH, oxytocin, we already mentioned that one, and all releasing hormone. There are different types of releasing hormone. One of the one over here, growth hormone, releasing hormone they are talking about. Is it clear? Releasing hormone source is hypothalamus. Okay. So, number 2, ectopic growth hormone releasing hormone secretion by known endocrine tumors, that is lung tumor, they are also produced with a hormone like growth hormone releasing hormone function, but they are not coming from the hypothalamus. Look at that one. 90%, 95% is coming, source is my hypothalamus. Is it clear? Okay. Ectopic secretion of growth hormone by known endocrine tumors. Treatment goal for acromegaly. Normalization of the growth hormone. I forgot. Thank you. Okay. So treatment goal for acromegaly is normalization as much as possible of the growth hormone response, oral glucose load, normalization of the insulin-like growth factors, removal or reduction of the tumor mass, relieving the central pressure effect from the tumor, improvement of adverse clinical features, normalization of the mortality. Actually, with growth hormone, with acromegaly, there is no treatment. So we can take only preventive measures, whatever he or she is having it right now. Look at our diagram. Do you folks know JLL? Night show, used to do JLL show. Person, no, yes. Do you remember the face? No. Mandible was like this. Long mandible. I'm just kidding. Maybe he's not having acromegaly, but his facial features looks like acromegaly. Is it clear? I'm just making. So don't tell him that you are having acromegaly. Yes. So face, long mandible, bones become thickened, eyebrows, white eyebrows, nose bridge, chin is protruded. So those are the features. Remember all those important. And that is a diagram on page of 1195. Okay. Oh, damn it. Which of the following is cause of tall stature? Marfan. Marfan syndrome is a genetic condition that results in rapid bone growth and late or absence of epiphyseal cap. Therefore, they are still growing because the epiphyseal plate is not closed yet. Epiphyseal plate is not closed yet, and the growth hormone doing their job, making the person increase in linear growth, tall stature. Okay. And all these endocrine system folks, first get the clear-cut idea of the endocrine gland, its normal secretion and normal physiology. If you can connect its normal with patho, the whole chapter has become very easy. But you have to know what is normal is. Okay. Now, precocious puberty, early maturity. Isosexual precocious puberty is early activation of the hypothalamic pituitary gonadal axis. They're talking about the hypothalamus, they're talking about the pituitary gland, they're talking about my testes or ovary. That's gonadal. Gonad. What is gonad? What is gonad?
The sex hormone?
Is a testes. Gonad is early stage of development. Testes and ovaries we call gonad. Gonad. Early stage of development. If the information is for the testes, that gonad will turn into testes, depending on what type of stimulation you are providing to that gonad. Gonad is early stage of my testes and ovary when we're still in the mother's womb. But because they are still, both these organs are originate from the same side of the human body. Testes comes out, ovary descend, but stays within the pelvic cavity. I said testes descend. Testes has to descend. Why the testes descend? Pardon? Why testes has to descend? Why the testes has to come out and stay this water? Temperature. Because the testes needs a cooler environment to function. If they stays within my inguinal canal or abdominal cavity, that testes turn into a cancerous tissue. Look at cancerous tissue. We have not only cancerous tissue, before that, it turned to fibrous, then cancerous. So we have to perform surgery before 2 years of age. We follow that one. I did a lot of operation of those testes. We call undescended testes. Okay. Now, this is resulting in the development of appropriate sexual characteristics and fertility. Person with precocious puberty usually are tall for their age as children, but short as adults because of early closure of the epiphysis. Look at that one. You folks need restroom break. You guys are okay to roll? Yes? We'll take break, so don't worry. Now the question is,
Sir,
yes? Somebody,
oh, never mind.
Roseanne? You are present, Roseanne.
Okay, thank you.
Okay. We are discussing something else right now. If you look at that one, the last paragraph, I'm explaining the last one over here. If female, if they have a hormone, estrogen in early age, they will start their menstrual cycle early. Number one, not only start menstrual cycle, enlargement of the breast, and everything coming ahead of time. Not that is the effect of estrogen, and also that estrogen in that female body causes closure of the epiphysis. And that child with early menstrual cycle, enlargement of the breast, they are short stature. Short stature because the epiphyseal plates are closed with this epiphyseal plate are closed because my estrogen works over here. Okay. That's why it says person with precocious puberty usually are tall for their age as children, but they become short as adults because of the early closure of the epiphysis. Causes of precocious sexual development may be idiopathic, maybe the disease of my gonads, maybe disease of my adrenal gland. Adrenal gland, that means adrenal cortex. Adrenal cortex is supposed to produce androgens. Normally they produce androgen, adrenal cortex. Not there. Now, next is hypothalamic diseases. Releasing factors. Gonadotropic releasing factors are not produced within the hypothalamus. And the last one over here says benign or malignant tumors of the CNS, which is not that common, but gonadal disease, adrenal disease, and hypothalamic disease are common. Okay, folks, I need to take a pause over here because of the different gland right now. Let's take a break of 15 minutes. Right now, 10:25 is returning time. 10:25 is returning time to folks on Zoom also.